Welcome to the NCLEX Crash Course. In this series, we'll cover topics like pharmacology, medical surgical nursing, pediatric nursing, obstetric and gynecological nursing, and psychiatric nursing. Don't forget to subscribe for more valuable NCLEX Crash Course episodes.
The major disorders of gastrointestinal system. So in the last video, we discussed 3 disorders of GIT system, including obesity and other disorders. Now in this video, we are going to see some more important diseases or conditions of GIT system. So let's begin with the video. So the first disease we are going to study is cancer of oral cavity. So what is the cancer of oral cavity? We will see etiology and pathophysiology. So primarily in clients who smoke, chew tobacco, or drink alcohol in large quantities, usually discovered by dentist. So these people who have history of smoking, chewing tobacco, and consumption of alcohol, and this is discovered by the dentist. So these people are prone to the cancer of oral cavity. Cancer of lip easily diagnosed. Prognosis is positive. Incidence highest in pipe smokers. So we can see here that it is very easy to diagnose the lip cancer, and prognosis of lip cancer is positive. Okay, it can be reversed back, and incidence of lip cancer is highest in the pipe smoker. So who smoke by the pipe have high risk of the lip cancer. Talking about cancer of tongue, it usually occurs with cancer of the floor of the mouth. So whenever the tongue cancer occurs, it includes the floor of mouth, and metastasis to neck is very common. So this is important that in the oral cavity cancer, if tongue is involved, so metastasis to the neck is very common. Cancer of submaxillary glands, highly malignant and grows rapidly. So this is also important that the highly malignant cancer is of the cancer of submaxillary glands, and it grows rapidly. So these were the different cancer of the oral cavity. Now moving on to the clinical findings. What will be the symptoms that we'll see in these patients? So first is the subjective clinical finding. What the patient will report. So patient will report pain, but this is not an early symptom. It can be seen in the later stages. Alteration of taste. So when the mouth or oral cavity is involved, so alteration of taste will be, easily detectable. And this the patient will report during the early phase. What will be the objective findings? Objective is that we are going to observe, we are going to see or examine in the patient. So that will be leukoplakia. So what is leukoplakia? It is the white patches on mucosa. So on the mucosa, or we can say membrane of the oral cavity, white patches will be seen. That is called leukoplakia, which is considered precancerous. So this leukoplakia is precancerous. Ulcerated, bleeding areas in involved structures. So there can be formation of ulcers, and bleeding can be seen in the involved structure. Also, lymphadenopathy can be seen. So swelling of the lymph nodes will be seen in the patients. So this was about the clinical findings. Moving on to the therapeutic interventions. So what are the interventions that we are going to provide to the client for the relief? So first is reconstructive surgery if indicated. So as we know, this oral cavity is very, very important in our body, as it is a very important part of the body, as it is helpful in ingestion of food. So therefore, reconstructive, that is, formation or gaining back the functioning of the oral cavity will be done using the surgery if it is needed. It can involve the plastic surgery and other things. Radiation or implantation of radioactive material may arrest growth of tumor. So if there is formation of tumor, so that tumor's growth can be arrested by using a radioactive material or an implant, or providing radiations to that tumor. Now, if there is surgery indicated or there is placement of radioactive materials. So at some point of time, total parenteral nutrition may be needed. So what is total parenteral nutrition? So whenever the patient is not able to ingest food or take food by mouth, so in that case, total parenteral nutrition is given, in which the food that we eat is given in the liquid form. So it contains the essential things like protein, vitamins, and essential carbs, and all things that we take by the mouth. Next is tracheostomy and tube feedings. So in the patient with oral cancer, tracheostomy will be done. Okay, so tracheostomy will be done to have a proper ventilation. And tube feedings. So as the oral cavity is non-functioning, so tube feedings will be done. For example, there will be nasogastric feeding or total parenteral nutrition. With extensive head and neck surgery, so if there is extensive head and neck surgery, in that case, the TPN will be given. TPN is given by the IV route. Antineoplastics. So what are the antineoplastics? So these are the drugs which work against the cancer or tumor growth. So it contains cisplatin, known as platinol, fluorouracil, that is adriosil, paclitaxel, known as Taxol, docetaxel, known as Taxotere, carboplatin, known as Paraplatin, methotrexate, that is Trexol, and gemcitabine, known as Gemzar. So all these are the anti-neoplastic drugs we have to remember, because sometimes you may be asked with such questions that what is the nursing responsibility of the with the patient who is on the cisplatin. So we should know that cisplatin is a anti-neoplastic, and for these patients there must be a caution care. Now, moving on to the nursing care of clients with cancer of the oral cavity. So, what kind of nursing care we have to provide to the patients having oral cancer? So, talking about the assessment, how we are going to assess and analyze the patient's condition. So, we have to take the history of the patient, a very brief and detailed history of hemoptysis. So, what is hemoptysis? That is the blood in sputum. So we have to take the history of patient with hemoptysis and pain, because in cancer, pain symptom can be seen, and these two symptoms are very common, so they should be asked. Baseline nutritional data. We have to take the nutritional data. For example, we have to measure the height, we have to see dietary intake of the patient and ability to chew. So it depends upon the degree of the cancer growth in the mouth, and all these things we have to assess, so that when we are providing care to the client, then we should have all the information regarding what is the current status of the patient. Third thing we have to assess is characteristics of lesions in the oral cavity. We have to see that what are the characteristics of lesion. If the ulcer is of one first degree, second degree, we have to see that, so that we can plan the nutritional intake according to that. Second is planning and implementation. How we are going to implement the things that are planned. So first is maintained patent airway. So as oral cavity continues to esophagus, and behind esophagus there is trachea, so there is a very close link between two of these. If there is any cancerous growth in the esophagus or oral cavity, so that can metastasize to the trachea, and that can affect the breathing of the person. So we have to maintain patent airway and always keep tracheostomy set at bedside. If there is respiratory depression, any kind of emergency, then tracheostomy set should be there to tracheostomize the patient. Second is maintain fluid, electrolyte, and nutritional balance. So patients having oral cancer will, it is obvious that they will develop the, deficiency of nutrition and impaired electrolyte fluid balance. Therefore, it is very important to maintain that we have to administer the total parenteral nutrition, we have to provide enteral tube feedings as ordered. Okay, so these things we have to take care of. Third is relieve dryness of mouth by frequent saline mouth washes. So we have to provide continuous, or we can say consistent oral care to the client, because we have to prevent infection in the mouth. So we have to always remove dryness of mouth by frequent saline mouth washes and ample fluids if receiving radiation therapy. So if patient is on radiation therapy and is not undergoing any surgery of mouth or tumor removal surgery, then we can provide ample amounts of fluids during that time. So we can do that. Fourth is consider time and distance in relation to the radioactive implants when at bedside. Okay, so we have to maintain the distance because we know patient is having radioactive implant. So we have to consider the time. We have to always remember the distance and time in relation to the radioactive implants when at bedside. Evaluation, what we are going to expect as a outcome in this patient. So what is our goal, and what we evaluate that there is maintenance of the airway patency and maintenance of the nutritional status. So these two things should be met. These two goals should be there when we evaluate the nursing interventions. So this was about the cancer of oral cavity. Now moving on to the next disease, that is gastroesophageal reflux disease. So gastroesophageal reflux disease, as indicated by the name, there is involvement of the stomach and the esophagus, and content from the stomach reflects back into the esophagus. So this is gastroesophageal reflux disease known as GERD. So this is backflow of gastric contents into esophagus, gradually breaking down the esophageal mucosa. Now we have to see here that what is the etiology and pathophysiology, why the GERD occur. So we know that esophagus is a hollow muscular pipe which is connected to the stomach, and there is a sphincter between the stomach and the esophagus. So when there is inadequacy of the lower esophageal sphincter, or we can say when there is impairment or any loosening in the sphincter of the lower esophageal, then the content of the stomach, which is acidic. So this is the acidic content, because here the HCl is released in ample amount to digest the food. So this acidic content when revert back into the esophagus. So corrosive effects of gastric acid on esophagus and delayed esophageal and gastric emptying. So when the food that is going down into the stomach is delayed, so the food accumulation here and continuous reflux of the acidic food into the esophagus will lead to damage of the esophageal mucosa. So we can see here inadequate lower esophageal sphincter tone, corrosive effects of gastric acid on esophagus, and delayed esophageal and gastric emptying. These are the three factors that can lead to GERD. Associated with hiatal hernia. So if patient is having hiatal hernia, that is also an association of the GERD. Obesity. If patient is obese, patient eats too much. So that can also lead to increase in the acidity in the gut and reflux of the food. Pregnancy. In pregnancy, it is also commonly seen that digestion is poor and the acidic content revert back due to poor sphincter. Caffeine, chocolate, and high-fat food ingestion. So all these things are the risk factors and etiology of the GERD. Now, GERD may lead to Barrett esophagus. So what is Barrett esophagus? So when there is a continuous, or we can say there is always reflux back of the acidic content in the esophagus, can lead to permanent damage, or we can say damage to the esophageal mucosa. So that permanent damage to the esophagus mucosa may lead to Barrett esophagus. And that Barrett esophagus is a pathological condition that can process into esophageal cancer. So if GERD occurs for a long time, if it becomes chronic, that can lead to Barrett esophagus, and that Barrett esophagus can lead to esophageal cancer. So this is about the etiology and pathophysiology of GERD. Moving on to the clinical findings, what we are going to see in these patients. So first is the subjective data. So the things that patient is going to report. Patient will report dyspepsia. Dyspepsia means that there will be indigestion of the food. Patient having dyspepsia will report many things. For example, the patient will report abdominal discomfort or burning in the stomach, or patient can report bloating, gassiness, nausea, or the patient will tell that he feels the feeling of fullness very quickly. So this is about the dyspepsia. So all these things the patient will report. Second thing is dysphagia. Dysphagia means there will be difficulty in swallowing. So there will be difficulty in swallowing. Heartburn, that is pyrosis, will be reported. Oral release of salty secretions. So the patient will report that there is release of salty secretion that is called water brash. So all these are the clinical findings that the patient will report having GERD. What are the objective data? What we are going to see in the patient? First is eructation. So what is eructation? Eructation means release of the gas from the mouth. It can be a esophageal or stomach gas that we usually call a burp. Regurgitation will be observed. Hoarseness of the voice, chronic cough, wheezing, recurrent pneumonia if severe. Esophageal pH reveals acidic reflux. Endoscopy reveals tissue damage. So all these are the objective findings that we will see in the patient. So due to repeated reflux of the acid, the pH of the esophageal will be acidic. And when we will do endoscopy, so the tissue damage can be seen due to corrosion of the mucosal layer of the esophagus. Now moving on to the therapeutic interventions. So after all these findings, it is very necessary to provide the interventions. So interventions can be pharmacological management. In pharmacological management, our goal is to decrease the acidity in the gut. So for that, histamine receptor antagonists will be given. Antacids can be given. Proton pump inhibitors can be given. Cholinergics and pro-motility drugs can be given. In dietary management, the patient will be advised to have small, frequent feedings, because if the patient will have small meals, so the acid will be released in less amount. Avoidance of spices. All these things trigger the acidity in the gut. So spices should be avoided, fats should be avoided, alcohol, chocolate, peppermint, and caffeinated drinks should be avoided. Avoidance of eating 2 to 3 hours before lying down or remaining upright for 2 hours after meal. Avoidance of overeating. So all these things help in decreasing the acidity or reflux. So we have to advise the patient to eat the dinner before sleeping at least 2-3 hours before lying down, or after the meal the patient should walk for at least 15 to 20 minutes or remain upright for 2 hours after the meals, or avoid overeating. And these are the things that can trigger the acidity in the gut, that for example alcohol, chocolate, peppermint, caffeinated drinks. So all these things will increase acidity in the gut. So the dietary management should be like this. Also, weight reduction if indicated. Okay, so in obese patients, GERD is commonly seen. Therefore, weight reduction will help in decreasing the appetite of the client, and that can help in intake of less food, that will help in decreasing GERD. Eliminating smoking. So, smoking also triggers the GERD. Surgical intervention if medical management is unsuccessful. So, if the patient is not able to be managed by the medical management, so surgical management can be done. That is Nissen fundoplication. So, what is Nissen fundoplication? Sutures tighten fundus around the esophagus. So, in this surgery, the esophagus is tightened by the sutures around the fundus so that the stomach content do not moves up in the esophagus. Next is endoscopic therapy, that is strata procedure. In this, radio frequency energy at high temperatures via endoscopic catheter causes tiny lesions in less, while under conscious sedation causes tissue tightening, establishing barrier to reflux and reducing less relaxation. Okay, so in this surgery, what we are going to do that by using the radio frequency energy, that is a high temperature energy, we will insert the endoscopic catheter and tiny lesions will be created in the lower esophageal sphincter, and it will be done under the sedation, and through this the same thing will be done. The esophagus will be tightened so that the content will not revert back in the esophagus. So these are all the interventions that